Assalamu alaikum, the long clinical consultation day. First scenario, 60 years old female came with the difficulty in breathing. Please take history, examine the patient, and address her concern. Julia Smith, okay?
Yeah.
Here you go.
Hello, I am Dr. Muhammad. I am doctor in clinic today. I need to confirm with me, Miss Julia Smith, 60-year-old.
Yes, Dr. Muhammad.
Okay, Miss Julia, today we are here to discuss some issue regarding your health. I will take some history and examine, and we write some notes. All will be confidential if you don't mind. It's okay for you?
Yes.
Came to my mind that you're coming today by some difficulty of breath. Can you tell me more about this?
Yes, doctor, I have noticed that in the last few months, I have some difficulty in breathing and I become very short of breath, especially when I walk around. So that's why it's getting progressive. So I wanted to see you because my GP thinks that this is something which requires evaluation.
I am so sorry if what's happened for you, Ms. Julia. Can you tell me more? This coming suddenly or gradually?
No, it's gradually.
You did feel any chest pain before it?
No,
Any sweating or any upper chest pain or
no chest pain, no sweating.
okay? This increasing by time, as you mentioned, right?
Yes.
You feel it more during coming upward stairs or during more effort?
Yes, but even at rest, I do feel short of breath.
From the beginning, it started even by rest, or by the time become
No,
more
no, no.
and
I mean, it is progressively getting worse now.
okay. Did you feel any swelling in your limb?
Not really.
Okay. Any heart racing?
No.
Any
Good
coughing?
morning.
Sorry.
Coughing.
Yes, I do cough.
It is dry or wet?
Mainly it's dry.
Okay. Also increasing by effort?
No
At night, you are sleeping how much?
pillows.
How much you are lying when you're lying down? You feel more difficult of breathing.
No.
How much pillows you are sleeping on it?
Two.
Increased than before?
No,
This is the
that's my
same.
normal. That's my normal.
Okay. You are not awaking from night searching for air.
No.
Okay. This cough also this few months or before?
Yeah, just recently in the last few months.
Okay. You feel anything more make this breathing more better when you are resting or doing anything?
Yes, previously it was better when I rest, but I think now it's pretty much all the time.
Okay. Any increase in body temperature?
No.
Any feeling any lump in your body?
No.
What about your weight?
My weight seems stable.
Okay. Any other preferences?
No.
Okay. Any feeling joint pain?
Yes, I do.
Which joint?
I mean, I have a problem, so that I have been diagnosed with rheumatoid arthritis about 5 years ago. So I have been on medication. So my joint pain, I mean, it's kind of an up and down, but at the moment it's okay.
Okay. No swelling, no hotness in it?
No, I haven't noticed anything. I mean, I'm not worried about my joint pain at the moment. I'm more bothered by this
You
breathing
are
problem.
following you are following with the joint clinic regularly?
Yeah, I have been. I mean, obviously, because my joint problem was relatively okay, so they are just seeing me after 6 months.
Okay. Last time they are telling everything is okay.
Yeah,
What about medication you are taking for it?
yes, I have been taking this injection, which is once a month, rather, sorry, every 2 weeks called adalimumab, and then I'm taking this once a week pill called methotrexate, and then another one which is called sulfasalazine.
Okay. Any change on the doses of this medication or updating anything for it?
No, I'm in pretty much on the stable dose.
Any other medication you are taking? Any medication list you have?
No, apart from that, I'm not on anything. No,
No diabetes, no hypertension?
and no.
Any family history of note I should know? Any malignancy, anything?
I have a family history of diabetes and hypertension.
Okay. Any allergies from any medication?
No,
Okay. Did anyone notice you have you are more pale nowadays?
no,
Any dizziness when you stand from line to stand up?
no,
Anyone notice your eye more yellow?
no.
Any tightness in your skin?
I haven't noticed anything.
Any muscle pain or weakness?
No,
Any sore in your eye?
no. But my eyes at time I feel that they're more dry.
Is it new for you? The dry eye?
Yeah, recently, I mean, in the last 1 year, and I have been using these artificial tears.
Okay. Any redness?
No,
Any vision problem?
no,
Any headache?
no.
Any dry mouth?
Yes.
Okay. Since when?
Again, for the last 1 year, and I have been using these chewing gums to help with my saliva, and they are, I mean, working. Yeah.
Sorry for that. Okay. Any white patches or any you notice any sore in your mouth or any changes in the color?
In my mouth, no,
Any difficult swallowing?
no,
Any heartburn or heart brush?
no,
Tummy pain?
no,
Change in your bowel work? Any black stool, blood stool? Any change?
no,
Any change in your water work? Increase or decrease or blood or any change in it? Frothy?
no,
Yeah. I asked before, no swelling in your limb, right?
no.
Okay. Any travel history soon?
Yeah, I have just recently traveled to uh, India.
Any you take your vaccination before going there?
No, I haven't had any vaccination.
Okay. Any increase in body temperature?
No,
Any sweating at night?
no, I told you no,
Any contact there with any sick person or anyway?
no,
Okay. Sorry for this question. Any using any part drugs? So
no,
injection or any sharing a
no,
needle or stone? Any blood
no,
transfusion before?
no.
Did you take your TB vaccination at childhood? You know your vaccination schedule?
I'm not sure about that.
Okay. Any
But
unsafe
I have a
infiltration?
sorry, I have a scar, and my doctor told me that this is a scar from the TB vaccine. There's a scar
You
on
know,
my left arm.
you know about the test for you, your TB status before giving your medication for your joint problem?
Yes, I think that they tested me for TB before starting this adalimumab injection. Yeah,
Any smoking?
I do smoke
How much?
4 to 5 cigarettes a day.
Okay. We advise strongly to hold smoking to help us for your respiratory problem, okay, your lung problem,
Okay.
okay.
All right.
What about
I,
alcohol?
no.
What's your job, Mr. Miss Julia?
Yeah, I work in a manufacturing factory.
Manufacturing factory. What is
Yeah.
you know the substance you are dealing with, coal or
I mean, so
any?
basically it's a tire manufacturing company. So we do make vehicles tires.
Okay, okay. You noted that you're how many years you are working there?
I mean, around 15 to 20 years at least, or maybe even more.
Okay, Mr. Ms. Julia. What about your period? It's irregular? Any bleeding there? Any including bleeding?
Well, I think that I achieved menopause when I was around 48.
Any taking hormones or any
No,
medication?
no.
Okay, okay. Any problem in you have children before?
Yes, I had.
Any problem in your last pregnancies?
No,
Any clots before?
no,
Okay. Or no family history of any clots?
no.
Okay. Can I examine you, Ms. Julia?
Yes.
Okay. Generally, how is the weight of the patient?
Weight.
Yes. Looks
Weight is
fascistic,
okay.
looks
Yeah.
underweight.
Oh, no, seems okay.
His hand, any clubbing there?
Yes, there is.
Okay. I will show any connective tissue about the his joint. I will look and feel any activity in the joint, uh, uh, any hotness, redness.
Yeah, so there have been some subluxation of the radioulnar joint, and there is also chronic synovitis in the bilateral symmetrical polyarthropathy, but at the moment there is no tenderness.
Okay. She can. I will give to test the function. She can button and button her hand, her clothes.
Hmm. She
Yes,
can.
she can. Okay. Proximal myopathy.
No,
Okay. I will go any pallor or jaundice in the eye.
no,
Okay. Any lymph node. I will test for lymph node anterior cervical, posterior cervical, submental,
no,
supraclavicular.
no,
Generally, the facial, any dropping on eyelid, any ptosis, any fissure of Horner syndrome.
no.
I will examine chest, complete examination for the chest by inspection palpation, how the any restriction in the expansion,
Yeah, chest chest movement seems to be reduced bilaterally.
equal bilateral.
Yeah,
Okay. About the percussion note.
percussion node is impaired in the bilateral basal areas.
Okay. I will here by stethoscope any fine rails at basal. I will ask the patient to cough, change
Yeah,
or not.
there are bilateral fine fixed crepitations.
Okay, I will put my hand on the apex, any change in the apex, and any loud B2
Where you will look for the loud P2?
in the upper right second intercostal space, parasternal,
Hmm.
left.
Okay, no,
Okay, I will hear any gallop, S1, ST3, any gallop, any murmur.
no,
Okay, abdomen, I will examine abdomen firstly for any splenomegaly,
no splenomegaly.
lower limb, any edema, any sign of DVT, edema, hotness.
No,
Okay, to complete my examination, I need to do spirometry for the patient and check his saturation and how's the respiratory rate of him? Fair.
yeah, respiratory rate is 22,
Okay, looks distressed.
slightly.
How much saturation?
Saturations are 94.
Okay. What's your concern, Ms. Julia?
Yes, doctor, I just wanted to ask you that obviously I'm concerned about my breathing issue. So can you please tell me what's the reason?
Yes, Ms. Julia, I appreciate your concern. And after taking history and examination, we have few possibilities for this. My first possibility, some scarring or soreness of your chest, of your lung regarding the medication for the joint problem you have, called methotrexate. Second thing also can be related to your job because you are 10 to 15 years exposed to this material also can cause soreness of your lung. For now, we need to admit you to full our to do full workup and do some imaging for your chest to complete our diagnosis and start management, and to share our joint doctor. Maybe we need to change your medication after that.
But I have been taking methotrexate for more than 5 years without any problem.
Yes, your words is valid, Miss Julia, but sometime it not come suddenly. It may take months or sometime years to be appeared. That's like we have that happen with you.
Mm. Doctor, I'm worried. Can it be a cancer?
I appreciate your concern, Miss Julia. This is one of the possibilities. You are right. We will put on our mind and we'll start after doing imaging. We'll see if there is. We update you about the results. But I need to confirm, Miss Julia. I asked about you any weight loss you have.
No.
We asked about any alarm sign for this high risk cancers, but for now it is not there. So, but we will put in our mind and we will update you if any result positive regarding.
Okay.
Okay.
All right. Thank you.
Okay,
Okay.
time is up. Sorry, Dr. Mohammed, I didn't remind you for 2 minutes. Now you can start the exam question, Dr. Hisham.
Yeah. So please briefly give your uh,
We have Miss
clinical
Julia.
presentation in
Miss Julia
different.
Smith. Miss
Sorry.
Julia Smith,
Mhm.
60-year-old female coming with difficulty of breathing, shortness of breath, started gradually and progressively since 6 months on background of well-controlled rheumatoid arthritis by and adalimumab. She already confirmed that she take her vaccination and checked for TB before doing this, before starting. She has also, by examination, no activity with the rheumatoid arthritis now, and chest examination showed showed a restrictive pattern of lung disease, of interstitial lung disease, confirmed by decreased expansion bilaterally and fine crackles fixed, not changed by cough on the bilateral basal. Also, in her background, there is she is working professional high-risk exhibition for tire material for 15 years. Uh, uh, no criteria for pulmonal or pulmonary hypertension till now by examination, but need to do.
Okay. So what is your differential diagnosis?
My differential diagnosis, firstly, drug-induced interstitial lung, drug-induced lung fibrosis by methotrexate. Second one, occupational related lung disease. Third, lung cancer. Against that, no alarm sign by taking history.
Mhm.
Third thing, also reactivation of TB, also, but no alarm sign and patient take his vaccine. Uh, uh, I need uh, I need to rule out any heart attack also before, but against that, no chest pain, no previous history of no risk factors. Uh,
Okay. Anything else?
Also, we have maybe started another connective tissue disease, Sjogren, because we started to have dry eye and dry mouth. Also, I need to rule out by antibodies and serology for
Okay.
this.
Can it be a mixed connective tissue disease?
Yes, maybe mixed connective tissue disease, rheumatoid arthritis with Sjogren disease.
Hmm. Any other component of the mixed connective tissue disease she might be having?
I rule out no rashes for systemic lupus, no skin tightness or
Have you examined?
microscopic.
Have you examined her for skin tightness?
No, I asked by history, but I didn't do the examination. Right.
Mhm. Has this patient got Raynaud's?
By history also, I didn't confirm.
Hmm. All right. Okay. Is there a possibility that this lady might have a idiopathic pulmonary fibrosis?
It will be one of the possibility, but in view of her risk factors, and it will be by exclusion
Mhm.
after adjusting her medication, after adjusting and locate his job, and all this for risk factors for the interstitial. At the end, we can say it is idiopathic.
Mhm. So, out of lung cancer, reactivation of TB, and idiopulmonary fibrosis, out of these three, which one is more likely?
More likely, uh, drug-induced.
No, no, no. I know drug induced, but my point is out of these three, I know
Mm,
drug induced is fine. Lung cancer, TB, and idiopathic pulmonary fibrosis. Out of these three, which one is more likely?
idiopathic pulmonary fibrosis.
All right. Okay. How you will investigate her?
Firstly, I will patient for admission. Will start apart from basic CBC for anemia, basic liver and kidney to be maybe affected by the medication, SRCRB for the activity of connective tissue and
Hello.
rheumatoid.
Mm-hmm.
سامعني? You hear me?
Yeah, yeah, yeah. I think, yeah, now I can hear you. Yes, please go ahead.
I will send for activity of rheumatoid. I will send anti-CCB rheumatoid factor, ANA for mixed connective tissue, RNB, also for Jogren, but I don't remember the. Uh, I will from beside the patient. I need to do spirometry and full parameters of bedside monitoring and EPG. I will send for imaging chest X-ray to see GGO and reticulonodular, and for CT high resolution CT chest for GGO or honeycombing. Uh, we'll also do pulmonary function test in sputum. We'll send sputum culture also, but we denied any.
Mhm.
Uh,
And what you are expecting in the pulmonary function test?
will be a restricted pattern FEV1 over FEV2, and the net result will be normal.
Sorry?
FEV1 will be reduced and FEV2 will be reduced, and the calculation will be normal.
Ratio will be normal.
Ratio will be normal.
All right. Okay.
Restricted pattern.
All right. Any other investigation?
I will check also for her and
Sorry, check for what? Sorry, your voice is
I,
breaking
I
up.
will I will check TB status, and
TB status, right?
virology screen, yes.
Uh-huh. Which virology screening?
Hepatitis B and C and HIV. Despite no risk, but she's on immunocompromised medication. We need to confirm.
Okay. Anything else apart from that?
Uh, if
You men-
suspicion of malignancy like mesothelioma or كده, it will be biopsy.
Okay, all right. You mentioned to the patient that initially you mentioned you will do a spirometry at the bedside. Is it something which generally is done at the bedside?
Spirometry?
Yeah, you mentioned that I'll do
Yes,
a
yes.
spiro.
Can be done beside, yes.
Hmm. So you think
Can
that
be
okay? How you will manage this patient?
by multidisciplinary team, sharing our pulmonologist, rheumatologist, suspicion, some more for oncology, will be oncology, occupational respiratory therapist. After that, patient will be review his medication, and the pulmonologist will see if antifibrotic medication like by birfenidone or other one. We'll check the EBG if it would need for long-term oxygen therapy if not only than 7 point.
Sorry, your voice is breaking up. I don't know whether it is for only me or everyone else feel the same. I don't know, but your voice is not very clear.
Last thing you hear what?
So I understand that you're telling about the medication which you are. So if you can just quickly tell, so I know the non-pharmacological, the team and all, if you can just mention the pharmacological management.
The pharmacological will be there is review for her medication, methotrexate by the pulmonologist and rheumatology. Then we'll assess the benefit from the antifibrotic medication like birfenidone. We'll check the need for long-term oxygen therapy. If VO2 less than 7.3 or less than 8 with pulmonary hypertension, core pulmonale. Will also allocate her job by the occupational health.
Okay.
It will be also nebulization, antibiotics if there is suspicion of exacerbation, bronchodilator, like this.
All right. And
Vaccination
this
also.
patient, yeah,
Can this
can this patient drive?
I assess the function of the hand, and she's doing buttoning well. And I should ask her if her driving is affected or not. If she is affected, it should be held until controlling the symptoms.
All right. Okay. Right. Any relation of the current symptoms if the patient tells you that I have some pets at home?
Yes. I should ask about any allergen, pets, vision, or any relation. If her symptoms become better if she's awake from home, I should ask about this and do reversibility test for this.
And if the patient says that I live in a village and I do lot of wood burning to cook my meals, so what would be the significance of that?
So if a lot of coal burning, this is a cause of fibrosis also if it is too much and for long term.
Yeah, so this is one of the risk factor for.
I will tell about these risk factors here.
Yeah. All right. Okay. All right. I think that's pretty much it. Oh,
Yeah,
thank you very much. Well done.
fair enough. Question. You can comment now, Dr. Chang.
Yes, I think that I think obviously he did very well. He covered all of the things, majority of the things. So, I mean, just to give a brief, because now when you know that this patient has a rheumatoid arthritis in the background and now having a breathing difficulty, so obviously the obvious thing is that you need to focus into something like an R rheumatoid associated ILD, or secondly the methotrexate, because rheumatoid in itself can lead to, there's an association of rheumatoid and ILD. So it could just be rheumatoid arthritis with ILD. Number two, it could just be methotrexate induced, which can happen at any time. So you are absolutely right. Secondly, I think that I would put rather a mixed connective tissue disease as one of the possibility as well, on top of the lung cancer or reactivation of the TB, because the symptoms was not showing any specific pattern to suggest it is tuberculosis. And regarding lung cancer as well, I think that the patient's weight was pretty much stable. So that was, I think, perhaps you can say that I would like to rule that out, but it seems unlikely. And then the other thing is, as you mentioned, that it could be occupational lung, or it could be even an idiopathic pulmonary fibrosis as well, considering the patient's age, examination finding of clubbing. So that could also potentially be. So I think that otherwise you are okay, but I think that the placement of your differential diagnosis, I think that if you could just put mixed connective tissue disease before the lung cancer and also idiopathic pulmonary fibrosis before that, I think that would be relatively better. As I already told you in the discussion that in the history you didn't ask about the Raynaud's, so that's important. You ask about the joint pain, so but you didn't ask. You ask about the pain in the hands, and but I don't see that you asking about pain in the other joints. Do you have any pain in the other joints, or any back pain and things like that? Urinary symptoms, I think you did ask very well. So because it was mainly the system involved, you need to do the cardiopulmonary, which you did it. I think you have done almost all the details of that. And then regarding MCTD, I think that you did very well. You covered for myositis, you covered for lupus, asking about rash. You asked about skin tightness, but I said that in mixed connective tissue disease, sometime the skin involvement is generally limited, so patient might not be pretty much aware of that and might not take notice. So this is something which you need to examine when you are examining. And obviously Raynaud's, you didn't ask about any digital ulceration as well. That was another question I think you could probably have asked. Yeah, and otherwise in the history, I think if I go by the scheme, I don't know whether Dr. Basim have shared the skills, so I can go by skill as well, just quickly. And uh, so,
Yes, I didn't write the skills. You can start by physical examination and
Ye-
then by finding.
yeah, so I think that examination was, I think that, I mean, you started examination of the joints when you were doing the general physical examination. You started examination of the hands, and then you started to look for the functions of the hand and all these things. Then you started checking. The problem here is breathing difficulty. So what I would suggest is that after doing just the general physical, the first thing you need to go is just to examine the respiratory, examine the cardio. After that, do the joint examination, because you need to go by the presentation. I'm not saying it is wrong, but I mean, obviously, that there is limitation of the time. Yes, patient have obvious rheumatoid arthritis, but this time the patient has presented with the difficulty in breathing. So you need to sort that out. So it's a focused examination. And after that, if you got time, you can say, I will examine the hands. Just imagine that if you are examining the joints and your time is up, you are left only with 2 minutes and you haven't examined the respiratory or the heart even. So I think that in this case, the priority should be to examine the lungs and the heart. And if the time allows, yes, you can go and examine the joints. And then, but if not, then you can tell the examiner that I would like to examine the joints to assess the disease activity in this patient. And if the time does, I hope you understand what I try to mean, because it's kind of a managing your time, that you need to prioritize your time. So I think that I would suggest that after doing the general physical, you just need to go straight away, do the full examination of the chest, do the heart examination, and once that being done, and if you still have time, then you can go and do the joint examination. I think that would be helpful. So even if you did not get any time, so I think that should be fine. Regarding, I think, the management wise, I think your differential, as I said, that maybe they might put you as a borderline, because things like MCTD and idiopulmonary fibrosis, I think that should come before reactivation of TB. And so I think that skill might be they can call it as a borderline. And otherwise, I think from management, I think they were fine. You have addressed patients' concern, and there were no welfare issues. So I think the only thing was little bit related to the differential. But as you know that the investigation, when you investigate for these things, so the other differential will be automatically covered. I don't know whether you have told, because your connection was disrupting so much, so I don't know that whether you have mentioned doing the, I know that you mentioned I will do rheumatoid factor, I'll do anti CCP, but I don't know whether you mentioned checking the anti RNP3 for mixed connective tissue disease or not, or anti Rho and anti La for the Sjogren's syndrome. So I don't know whether you have mentioned that. So I mean, that's something, if you have mentioned, that's fine. If not, I think you need to mention that as well, because if you are giving a differential of mixed connective tissue disorder, I think in that case you need to mention about these. And you can also mention, for checking the disease activity, you can do this the ESR and CRP. So overall, I think that, yeah, I think you have covered most of the things, and obviously they were okay. And I think that you did the relevant, uh, focused kind of a systemic review. So I don't see that there was any problem in that. And yeah, I think overall it was very well managed. So yeah, thank you very much.
Okay, thank you, Dr. Hasham. It's an exam case,
Yes,
classic.
it is.
Yeah,
It is.
it could be for you after a couple of days. It could be
Yeah,
your case.
yeah. It
Either
is.
you
It
or
is.
him. Yeah,
Yeah, definitely. I think that this is definitely one of the exam case, and I
yeah,
think the thought process behind this was to practice is that
yeah,
we need to know how to narrow down the differentials and
yeah.
give a
You're right.
sensible differential. So I was not looking for Dr. Muhammad to exactly tell me. So it was broadly being a differential diagnosis case, and it is very common. Very common. You might get it in the short case, or you might get in the long case. So I mean, every center have this case, so it can come at every center.
Yes, this is my comment regarding as a case. As a differential, I couldn't put the TB as a differential. Sorry, Dr. Mohammed, it cannot fit the case because you have bilateral fibrosis and mostly basal, right? Basal crackles. So I don't think it could be as a differential. You can put the rheumatoid itself and drug-induced and mixed connective tissue disease. All of them would be the differential. Cancer, I don't think also it's the differential, since the patient doesn't have any weight loss or a change of the appetite. I cannot put the cancer as a differential. Otherwise, the urinary symptoms. Did he ask, Dr. Muhammad?
Yes,
Because
yes,
I,
Yes,
okay.
yes, yes. I think
What do
he
you
asked.
think? Yeah, what do you think the importance of urinary symptoms here, Dr. Muhammad?
yes. It can be lupus as a mixed connective tissue as a female. It can be drug induced acute kidney injury. There is many things. It can be the kidney affected, like the
Yeah, tell
rheumatic.
me one complication mostly affecting rheumatoid arthritis, and they ask by name in the exam. Believe me, it will come, and they will not skip this question.
Yeah,
If you
I think,
have patient with
yeah,
rheumatoid,
amyloidosis, renal amyloidosis.
yes, amyloidosis. So for roughness of the urine, you can even specify the question direct and to this point. Do you have any fluorescence in the
I
urine?
asked it really about fluorescence.
Yeah,
Yeah, yeah.
yeah,
You
yeah. I'm
asked. Yeah.
talking. Yeah, you have to. Okay, what other cause? The drug induced as non-steroidal. The other thing as a complication, particularly the rheumatoid, the spleen. At least offer examination of a spleen, as
Yeah,
you
yeah,
know.
he mentioned. I think he
Um,
he said
Yeah.
specifically about spleen. Yeah, I was listening to
Yes.
that. He
Perfect.
said
So
that as well.
these
Yeah.
are the point they focus in the exam. Felty syndrome. It came as a Felty syndrome with rheumatoid,
Yeah, yeah,
either with the complication or
yeah.
amyloidosis or lung disease or pulmonary hypertension. So be ready to have discuss all these things. Don't forget the echo is very important as well to rule out pulmonary hypertension. To mention it as investigation, along with the examination of parasternal heave, loud P2, all the things you have to do.
And may require a right heart catheterization as well.
Yes, as invasive. If
Yeah.
you categorize the answer like basic blood test, bedside test, as I usually say, and specific, and imaging, and invasive, definitely you will impress the examiner whenever you mention for example, the imaging. You will start with the chest X-ray, then you can do high resolution CT chest, and it will show you either ground glass or honeycombing, right? So this is the case, how to drive the case. I think Dr. Muhammad do it in good way, but I prefer to ask about joint pain as a joint system as in the system review. Anyway, if you even start with your approach or my approach, you will catch the past medical history of rheumatoid arthritis. Then you can ask about the rheumatoid. What are the medication? Is it controlled? Did you increase or add any dose? Then go through the system review. Better to do this or that, whatever you want to do, but don't miss any system here. The skin is very important, the rash, all other manifestations, systemic sclerosis, difficult swallowing, dryness of the eye. By the way, it's not only Jagron, Dr. Muhammad, it's Sika syndrome, keratoconjunctivitis, Sika syndrome. You know that, right? And if you will stop driving, it will be related to the Sika syndrome, not to the joint. So the dryness itself,
He
yeah.
denied any blurring of vision, no vision problem at all.
Yeah, but he said I have dryness in my eyes, right? Dr. Hisham?
Stop for dryness
Yes,
or stop
yes,
for
yes.
dryness?
And I have been
Yeah, he
using
asked,
these
he said I'm
artificial
using
tears.
natural tears, yes.
No, no, no. يعني you are stopping driving for dryness. Many people have dryness. How come?
No, it's okay. Why not to stop? Dryness means the eye is painful. There is pain in the eye, and he might close his eyes for the pain, or he might have any danger while driving. This is one of the
I think that I will, Dr. Basim, I think
yeah.
that I will give the benefit of doubt to Dr. Muhammad because the patient didn't mention that he have any problem with the vision. It was just dryness. So I agree that a lot of time people. So I mean, we can sort that out by asking the patient that you have got any trouble driving. So he might mention in that case, yes, I do feel at time when I'm driving and if my eyes are very dry. So I find it a little bit uncomfortable. And then he can say, okay, I think that you stop. Because dryness, I agree that it is such a common thing and a lot of people use these eye drops and things. So I mean I feel that if otherwise they are feeling okay in terms of driving, because the problem is that a lot of the British examiner, when you stop something which wasn't relevant, so then generally they're not happy. That why something has been stopped, and these people, I mean, they know their rights and they understand that what's right and what's wrong. So my point is that if there is no problem with driving, then she can continue driving. But if he has noticed any problem driving, and obviously in that case, you need to advise against driving. That's
Yeah,
what I
I'm not
feel.
against this. I'm saying either this or that, not only the joint. I said even the option of eye vision fiction, you have to ask about and to consider it. Okay, I didn't say it's not to ask or it's not relevant. It's relevant if he asked and he said, yes, I have some vision issue or dryness in my eyes which affect. So you can do it. But the joint, it's okay. You can ask. But remember the point of eye also as well. This is my point, Dr. Muhammad. I'm not saying it's wrong
Yeah,
to ask about.
yeah.
Okay. Yeah. So both of them. Otherwise, perfect. Anyone has question or comment before moving to the next scenario? So the next scenario, I will read the complete Dr. Hisham, 50 years old, Mr. Farouk, with a complaint of recurrent hypoglycemic attack. Sit with the patient, take history, examine, and address the concern. 1 or 2 minutes, then we'll start.
regarding السيستميك اللي هو السيتي دي انا باخده انا I take it as a all, but this time sometimes the surrogate take you suddenly to the way يعني I didn't ask still about the history is the family and personal and past history. He take me from himself. I have some joint problem. I have this. Then خلاص he take you to the other track يعني. That's why I forget back pain. I forget Raynaud's like this.
That's why my advice always, if he start to drive you through something, stop him. Tell him, okay, we will go to this later on.
Yeah, Dr. Muhammad, when I did practice with you last time, you said that I took a lot of time. That's why this time I volunteered some information for you just to be quick so that you don't complain that I was very slow in giving the information.
Yeah, so he tried to correct. Okay. My point again,
Yeah.
if the surrogate start to say something which will waste the time and it's not in your approach and you'll be distracted away from your approach, at the same time, you might forget other things, which is very important. Stop him. Tell him, okay, we will go or we will come to this point later on. Just
Mm.
follow my question.
I was
Kindly. Yeah.
I was putting the differential as a age and the female cardio, then pulmonary. From pulmonary, I will go to the the family past medical history. If any drugs there causing this, then I will go to the connective tissue disease, going back to the pulmonary. And the bleeding in between, I will ask if from the beginning, I will ask any bleeding there if you are pale or like this. This was my approach. Then Dr. Hisham go على طول take me to the joint. Very good, yeah, ما شاء الله.
Yeah, he tried to correct, but
Yes,
it's
yes.
again mistakenly. He guided you mistaken way. Anyway, we are learning again and again. So please, whenever the surrogate start to be volunteer to say something which is not relevant and it will waste the time, save your time by saying, okay, we will come to this later on and do it in your approach. Definitely, you will be deviated and you will waste time and you will forget your approach and the scheme will be lost. Then you will be confused and the all organized way will be distracted. Why I'm saying always please follow the approach and stick to it. Okay? Dr. Hasham, whenever ready, you can start.
All right, I think that we can start.
Okay, here you go.
Hello, hi. My name is Dr. Fezar. I'm a doctor here. May I confirm that? Am I speaking to Mr. Farooq? Hello.
Yes, yes, I am Mr. Farouk.
All right, Mr. Farooq. So I understand that you have been getting some episodes where your blood glucose drop. Is that right?
Yes, doctor, it is horrible with me.
All right. So I'm sorry. I'll come back to that. And before going into that thing, may I know that have you got any past medical history of note?
Past medical history. If not, I have some problem in my gland in front of my neck, and
Mm-hmm.
uh, yeah, since 2 years I am taking medication called carbimazole,
All right.
uh, and I am following with my doctor
All
every
right. Okay. So apart from that, the problem in the glands, anything else?
no.
All right. Okay. Right. So now coming back to your current problem. So if you can just explain a little bit more to me.
Yes, doctor, what do you want?
So what
No.
exactly you feel, what kind of symptoms you have been experiencing?
Yes, doctor. Every while, maybe 2, 3 times by day, I feeling suddenly I am sweating, shaking, and when I go to the my GP is telling me your blood sugar is low. That's why
Uh-huh.
because many times it's happening this week, I afraid anything happened for me.
I'm sorry to hear about that. Yeah, that's obviously the concerning thing, and we'll try to sort that out. So for how long you have been experiencing these symptoms?
I think it was started 2 months back, one time, 2 time per week, but this time more 3, 4 times, and sometimes
Mm.
having day 2, 3 times.
All right, okay. And what exactly are the symptoms which you feel during those attacks?
So this is I feel shaking my hand, sweating, sometimes dizziness.
Mm.
I was about to faint one time with this, but my
Mm.
GP told me if you feel like this, take some sugary or candy.
Mm. And have you tried taking those sugary candies?
Yes, I take it.
And does that help?
Yes, that help for a while, but again, on
Mhm.
the same day, I have the same problem.
But when you take these sugary things, it does get better.
Yes, get better for a while. I feel it is not bad. يعني I feel my fainting or my dizziness little bit better.
Mhm. So it keep on coming back again and again.
Yes, again, again, again. Yes, and increasing this week.
All right, okay. And apart from this, have you noticed any racing and pacing of your heart?
Yes, doctor, you are right. I felt this also. One or two
Mm.
attacks yesterday.
Right, right. It is the first time.
Not first time, but it become more apparent this time. You
Hmm.
know, sometime I'm doing effort, sometime I feel this, but this time, even without effort, I feeling this.
Hmm. Right. And for how long you have this racing and pacing of the heart?
Also, same 2 months I started to, with the same time
Hmm.
I have this shaking hand and sweating. Then if I
Hmm.
did take any candy, it started my heart race.
Hmm. So after taking those sugary drinks, then your heart start racing.
No, everything become
Before that.
okay after taking the sugary.
Uh-huh.
Then
All
again,
right. Okay. Yeah.
I
All
have
right.
the
I
same
understand.
attack.
So have you noticed any problem with your waterworks?
My water work like what, doctor?
I
I
mean,
think
have you
it's
noticed? Uh-huh.
okay. I didn't notice anything changes.
Any change in the color? Any frothy waterworks?
No,
Hmm. Have you noticed any problem with your bowels, like any hard stools or any loose stools?
no,
Have you noticed any tummy pain?
no.
How is your weight generally?
Yes, doctor. My weight I think decreased about 4 kilos last 2 months. But
Mm-hmm.
my GP told me this is related to my gland problem in front of my neck.
Mm-hmm.
So I didn't bother myself by this because my appetite is okay.
Right, right. Have you got any have you got any weather preferences?
Yes, doctor. I am have this hyperactive gland, so I hate any hot weather.
Right, right. Okay. Okay, I'll just ask you some general questions. So have you noticed any headache?
Headache.
Mm-hmm.
The same with this attack. I have mild headache, but not too much affecting me.
And where exactly is that?
Full my head, the same.
All right, okay. And any problem with your vision?
My vision.
Hmm.
Last time when I have this fainting, I felt some blaring in front of me. But after taking candy, I become okay.
All right, okay. And have you got have you got any oral ulcers, soreness in your mouth,
No,
any dryness of your eyes,
no.
any skin changes
Skin changes.
in the skin?
This time, no. But I have one skin changes in my leg. When my gland problem started, and my GP told me it will disappear when you take the medication, and by the time become okay.
Hmm. So you don't have any skin rash or any other problem at the moment?
No,
All right. Have you got any difficulty in breathing?
no,
Any chest pain,
no,
cough,
no,
any weakness in your muscles, any
no.
prob any problem combing your hairs or changing your cloth?
Also, this doctor, beginning of my gland problem, it was very difficult for me to comb my hair, but with medication, I think it is okay. I can deal with my daily activity.
All right, okay, right. And I mean, apart from the history of that gland problem for which you have been taking carbimazole, have you got any other medical problem?
No,
Any other surgical procedures?
no,
Any blood transfusion?
no,
Any allergies?
no.
All right, okay. Have you got any family history of note?
I think also, doctor, my mother have this gland problem
Mm-hmm.
and his medication.
All right, okay. So she also been on the same medication?
I don't know
Okay.
really what is
All
her.
right, okay. And what you do for living, Mr. Farooq?
I am driver,
And what kind of, I mean, are you driving your own car or any uh, lorries
driver,
or, sorry?
driver.
All right. I would advise Mr. Farooq that you should not avoid should avoid driving because these attacks, if you develop during driving, I think they can potentially be quite serious. So till the time we sort that out, I would advise you not to drive. Is that okay?
Yes, doctor. Since I have a near fainting, I stop it. Yes.
Right. And do you smoke?
Smoking? No.
And do you drink alcohol?
Usually only at weekend.
Right. Okay. Uh, I just wanted to ask you one more thing. Obviously, it's a kind of personal question, but I need to ask. Are you married?
Yes.
Uh-huh. Have you got any casual partners? I'm sorry to ask about this question.
No.
All right, okay. Would you mind if I examine you at this point?
Yes.
All right, okay. So I'll start with the examination and I'll do the general physical examination. I'll check the pulse. I'll check the skin turgor, see if any sweating, cold or dry hands. I'll look for any pallor. And after that, I'd like to check the blood pressure, both lying and standing, and to look for any postural drop. Uh,
Yes. One by
so,
one, doctor. You will not forget. I will not.
sorry?
I will not remember everything. One by
Okay.
one, I will tell you. Regarding
Okay.
the
So,
blood pressure, it is
uh-huh.
130 over. It
And
is 130 over
no
90.
postural drop?
No, there is a mild positional drop.
Uh-huh. How much is I mean, postural hypotension? Is he getting postural hypotension?
Yes, there is positional hypertension mild.
All right, okay. After that, I would just like to, as I said, that look into the skin for change in any skin color.
Skin color? No,
I would like to examine the patient's face to look for any pallor or jaundice.
no,
Uh, After that, I would like to examine the patient's oral cavity to look for any oral ulcers.
no,
One thing I would like to check in the hand is to see for any evidence of clubbing.
no,
All right, okay. After that, I would like to examine the abdomen of this patient to look for any tenderness or any palpable viscera.
no.
Right. After that, I would like to examine the heart of this patient.
Its heart rate is 90, 95.
95.
No, no, no gallop, no artificial sound.
Irregular. The heartbeat
Yes,
is regular.
yes.
Right. I would also like to check, examine the lungs and especially look for any signs of heart failure, basal crepitations.
No, okay.
All right, okay. I just like to ask a few more questions related to your history. So you said that you have lost 4 kg of weight. Have you noticed any change in your diet or is it something unintentional?
It is not intentional, and my appetite is okay.
Uh-huh.
And my
All
GP
right.
told me,
Sorry?
and my GP told me this is related to my gland. They will review my
All right.
my
And have you
my
got,
thyroid.
sorry, one more thing I just wanted to ask you. Have you noticed any numbness or tingling in your hands and feet?
No,
And have you ever had any seizures?
what?
Any fits?
Any fit?
Mm-hmm.
Uh, fits? No, only the near fainting. Please, Dr. Basim,
Oh,
share the picture. I send you a picture.
okay. Uh, Regarding your gland problem, so you said it's being diagnosed 2 years ago.
Yes.
So what were the symptoms at that time?
What?
What were the symptoms at that time when you were diagnosed with that?
Yes, I was very anexic, and my weight decreased too much. And I have some blurring of vision. I have tremors in my hand.
Mm-hmm. Right, okay. And have you been under regular follow-up with your gland doctor?
It's
Yes,
short
yes.
now.
So you have been, and when was the last time you saw your gland doctor?
2 months back.
And are they happy with your progress in terms of your gland disease?
What?
Are they happy with your progress in terms of your gland disease?
Yes, he was happy, but he's telling me in more follow-up, and he was worried about this hypoglycemia or this blood sugar problem, and told me if the problem increased to come to the hospital.
All right, okay. Uh, right. So, Mr. Farooq, may I know that what exactly are your concerns? And before going into that, have you been on any over-the-counter or any herbal medications?
No,
All right, okay. So, may I know what exactly are your concerns?
doctor, what's happening for
Too many
me? Is it
steps.
cancer?
Yeah, sorry.
Yes, doctor. What's happening for me? I am afraid it is cancer.
Yeah, I fully appreciate your concerns. So, I think that based on the symptoms which you have told me, I think that you might have a condition which we call insulinoma. So it is not a cancer. Basically, it is a benign. Majority of the time, it is a benign condition in which your body, the glands in your body, they start producing more insulin, and that can lead to these recurrent episodes of low blood glucose. So I think that's something which I am suspecting based on what you have told me. So I don't think that it looks like anything concerning or anything like a cancer. Obviously, it is concerning, but it doesn't seem that there is any kind of a cancer.
So it is treatable, doctor.
Yeah, most of the time. So as I said that we just need to. So first of all, let me tell you that we just need to admit you for further workup and to find out what exactly it is. But if it turned out to be an insulinoma, so majority of the time it is a treatable condition, and there's a good chance that after once we find out that where exactly is the issue, so it can be fully managed and it could be surgically resected, and then your symptoms would most likely be settled.
Okay, doctor. Someone of my friend told me this is maybe you have diabetes. But this is how common I have this glucose. My glucose is
Yeah,
low.
yeah, I fully understand and appreciate. I mean, at the moment on when you have told me your history, I didn't find anything to suggest that you have diabetes because you didn't have a increase in your water work or any increased thirst. So, and obviously the low blood glucose in diabetes is something which happens when you are on any medications or if you have a kind of a long-term disease and for various reasons, but I don't think that's the case with you. So it seems relatively unlikely. Uh,
Okay, thank
so
you.
me, right, okay. Anything else? Any other? So I just wanted because obviously so are you family dependent on you?
So I am the only caring for my
Yeah.
wife and
All
my
right. So
family.
right. So I think that when we'll be admitting you, obviously, so we'll involve our social support team as well to help you in that regard till the things are sorted, so that
Okay.
your family are fully supported. Is that okay?
Thank you, doctor, for support.
All
Thank
right.
you.
Thank you very much.
Time is up. The examiner questions.
Yes, doctor, tell me what's your best finding.
Yeah, I think that this gentleman, 50 years old gentleman, Mr. Farooq, who came in with recurrent episode of hypoglycemia with a classical Whipple triad, symptoms getting better with intake of carbs, and uh, along with that, he has a background history of thyroid disease, which I feel that most likely it is a Graves' disease for which he is taking carbimazole. Uh, the symptoms, most of the symptoms, they are compatible uh, with the current, I mean, issue of the gland and also the recurrent hypoglycemia. So, based on my history and examination, also suggests that he is having some postural drop as well. And along with that, there were certain signs to suggest an active thyroid disease as well. So, based on these recurrent episodes of hypoglycemia, I would I would consider a possible diagnosis of an insulinoma. So that is something which I would like to rule out. And yeah,
Other differential?
he didn't give me any history to suggest that this patient uh, have any uh, kind of an other autoimmune problem like Addison. I've asked about these things, but didn't mention anything to suggest that this patient have Addison. But in view of the postural hypotension, I think that's something I would like to rule out as well. And the thirdly, he didn't mention anything, any use of any other medication which could potentially be responsible and lead to a nitrogenic hypoglycemia. But that's something I would like to consider if I am unable to find any other cause for that.
Can be alcohol liver disease,
I think I asked about the alcohol.
but he take binge alcohol in weekend.
Sorry?
He is taking binge alcohol in weekend.
Uh-huh.
Okay. Can be secondary hypocorticolism, not Addisonian.
Secondary what?
Secondary adrenal, secondary
Yeah.
hypocorticolism.
Yeah, I think that could be one of the possibility. I told that this is something which I would like to rule out.
Okay. What's your investigation?
Yeah, so first of all, I think that I would like to admit this patient. I will ask him to stop driving, and obviously, I would ask him to avoid alcohol. In terms of the investigation, I would like with a simple blood count. I would do a complete blood count. I will do the UNEs to look for the renal function and also the electrolytes, especially to look for any electrolyte changes of hyperkalemia and hyponatremia. I would also like to do a blood glucose as well for this patient and also like to request a HbA1c. Regarding further investigation, it will need a thyroid function test considering that background history of thyroid problem and on carbimazole as well. In addition to that, I would like to investigate him further by doing an endoscopic, but before endoscopic ultrasound, I think I would like to do a 72 hours fasting test while keeping him in the hospital to look for evidence of hypoglycemia. So,
You will do 72 hours supervised, and he already has many attacks of hypoglycemia and measure it.
yeah, I mean, it looks that way. So, just, I mean, obviously, and
You
CP has,
measure it beside the patient.
sorry?
You measure blood glucose besides the patient now.
I think that we can do a baseline reading, and obviously, if the patient becomes symptomatic in the hospital, we can do that as well. And we can even do that 72 hours fasting to see how much is the drop in, because that will be supportive of the diagnosis. And if that's the case, then we can investigate him further with further investigation like pro-insulin level and C peptide level. And also, I think that he will benefit from imaging like a CT scan of the abdomen or even more so by an endoscopic ultrasound to look for any evidence of a pancreatic insulinoma. So I think these are the things which I would like to investigate him for.
If I told you he measured one time or two time in GB and the RBS blood glucose was 2.1 millimole, you will do also 72 hours observe it?
I think that if it has already been documented by a medical professional, so in that case, I don't think, I think that's already documented hypoglycemia. So I would like to investigate for the cause of hypoglycemia in that case.
Okay. Any other investigation?
I would also like to do a 9 a.m. cortisol level to look for any possibility of and if the cortisol levels, I mean, it, obviously, if they go with an diagnosis of the Addison disease, then I would like to do the what we call, I forget the name for Addison disease. If the cortisol levels they are low, then I would like to do that Schwarzenegger test.
Okay. What
Yeah.
about your treatment management?
Yeah, so first of all, I would like to start with the education of the patient, just to tell that what to expect. I will explain all the detailed symptoms uh, of the hypoglycemia to the patient. I would like him to give. I would like to give him a medical alert bracelet so that if he develop any severe hypoglycemia, so that the people around him they must be aware that this patient has a history or it has a problem with the hypoglycemia. So a medical alert bracelet, I will give that. then I would I would educate the patient on if he start developing these symptoms, so he should have sugary candies with him all the time, so that he can have those things whenever he feels that his blood glucose is dropping. The other measures I would like to do is that I would like to involve the I would ask the patient to stop the driving, because this could potentially be serious. In terms of further management, I think I would need to involve multidisciplinary approach. I'd need to involve a endocrinology team. I'd also like to involve the occupational health team as well, because of the concern related to the patient being the sole earner of the family. I would also like to educate the patient to avoid alcohol and any binge drinking. In terms of the medications, so most of the time, once the diagnosis is established, so if it is confirmed that this patient have an insulinoma, uh, the best would be to see if that could be surgically handled, because if there's a single area of insulinoma, in that case, we can target it with a surgical resection. If that's not appropriate, so I think that we can, I mean, if it is an insulinoma, so I think that, I'm not sure, but I feel that there is something we can give, like a somatostatin analog, so that could potentially help as well. So yeah, I think these are the things in terms of the management of the patient.
Uh, what do you think insulinoma will come with this weight loss like this?
Now, this patient have, I mean, obviously a thyroid disease as well. So in that case, the symptoms may be a little bit masked. So generally, if you have a pure insulinoma, in those case, when obviously because of that sudden surge in your insulin level, and the patient tend to eat more, so majority of the time it comes up with an increase in weight and recurrent episode. But since this patient also have, I feel, most likely a Graves disease, so that is why that feature is not very prominent in this patient.
Any advice regarding his diet?
Yeah, I think that regarding his diet, I think we need to involve the dietitian as well to guide. So I mean, he should have a high carbohydrate diet in order to help with these episodes as well. And yeah,
High
so I think that,
carbohydrate.
yeah, and he should have frequent meals to avoid any episodes of hypoglycemia.
Yes, yes, doctor. Other?
In terms of management,
Yes.
uh,
Any role of glucose steroids, immunosuppression?
steroids and immunosuppression
Yes.
for insulinoma.
You suspect hypocorticolism, right?
Yeah, hypocortisolism in that case, as I said, that if that's diagnosis established, in that case we can put the patient on steroids. But as I said, that it depends that whether that diagnosis has been confirmed or not. So yes, if that's been confirmed, in that case we will need to educate the patient on that line as well, and will need to be on steroid replacement as well.
Yes. Okay, thank you.
Thank you very much.
Okay, one question, Dr. Hisham. What you can name this condition or give me a term of this possible differential other than you mentioned?
Uh, for what?
Thyroid and Addison, diabetes possibility.
Addison, Dr. Bassem. This is not Addison.
So
Okay,
you're
if
saying
you
that a
consider,
term
yeah,
for Edison and Graves together?
yeah, thyroid
I mean,
and yes,
if it is because Graves is an autoimmune and Edison is an autoimmune as well, so maybe it could be something like an autoimmune polyglandular type thing.
yeah, this is what I want to hear. Okay, now you
Yeah.
can comment, Dr. Mohammed. Yes.
Okay. So, Dr. Hisham did very well. He exclude the most common causes. So, this case, I was attended. It is rare and not coming in the exams, I think, before, but they put it because many cases they found it in the real life. Regarding we'll take one by one كده الهيستوري. you were more targeted دكتور هشام. يعني you were more targeted. يعني I think not systemized exam, only you go to the systems. But when the patient and you take too much time in the go and come back to the how is feeling the patient, and it's خلاص the scenario coming to you, he is have hypoglycemia. This mean he already measured it and knows there is hypoglycemia many times. So we'll start with he telling he has weight loss and يعني his appetite. He told he's okay, but I think it was not okay. The appetite was also affected. But sorry, I didn't mention this, but it was affected little in the last 2 months. The most common causes, as you mentioned, insulinoma, right? But against that, there is weight loss. Second thing, Addisonian, but against that, no pigmentation anywhere. But there is positional hypotension and there is positional dizziness. So that's why one of the differential hypocorticolism, secondary adrenal, not primary. So third thing you mentioned about, I think you didn't ask in your discoloration of your eye. طبعا you asked about jaundice during examination. About alcohol, you didn't take full. Even during the examination, you didn't ask any clinical stigmata of chronic liver disease. So this is very important. Any alcohol patient should be, and you think that this is maybe the cause of hypoglycemia, because organ failure is very important, liver and kidney. You asked well about kidney, no fruit urine, so kidney excluded of this. But need more history about alcohol, and during examination, search more about chronic liver stigmata. One very important question also you asked about the surgeries, but you didn't. You should make the examiner know that there is some bariatric surgeries need to be mentioned for the patient. He may be done with one of them to tell the examiner, I know that the bariatric surgery may cause this dumping syndrome or feeling like this after taking the carbohydrate meals. Also, important thing to differentiate about his mood. Maybe he's taking some medication, but he didn't mention, or his mood must be checked, or any stressful there must be checked also. Factitious hypoglycemia. We'll come to so the differential, it will be borderline. The main differential here, patient has Graves, right? He has Graves autoimmune, and there is a syndrome called autoimmune insulin syndrome. Patient, when he has any autoimmune disease, he has his hyperactive insulin. The cells, I think, a non-isolate cell, sometimes become hyperactive. Yeah, it is a syndrome called autoimmune insulin syndrome. He has, once he take any carbohydrate, his insulin will be firing, and he will feel this these symptoms. That's why when he take the carbohydrate, he's temporarily improved. Then again, has severe hypoglycemia. So it is an autoimmune condition. Recurrent hypoglycemia secondary to autoimmune insulin syndrome. This is the main, and this is related to his medication. You didn't think at all that carbimazole. I think carbimazole act as like some sulfonyl. He has some in the substance or chemical. It is like sulfonyl. So it is related to carbimazole. Should be reviewed his medication with the endocrinologist, because sometimes it stimulates this syndrome. Otherwise, other differential, the case came for the differential of hypoglycemia as you did. Rule out any Addisonian, any diabetes with its complication, rule out any organ failure, kidney and liver, alcohol maybe the cause, and that secondary adrenal, and the factitious if he any mood or any stressful and he's taking anything, any other medication. And you asked about this, about the any taken medication on hypertension. So we'll go to the examination. You didn't touch at all the thyroid, and even without picture, he's telling he has this. يعني he mentioned like a grave. He has a before and tremors, and you checked yes acrobacy from his hand, and even if you didn't touch the activity by putting any paper in his hand. Some activity, and this is one of the causes also of hypoglycemia. You didn't check lymph node, you didn't check the thyroid. At least even fast, يعني we can check that maybe some malignancy there. Also during the investigation, you didn't. I think I didn't hear you do any thyroid lab or to check يعني the activity.
No, I mentioned thyroid function test. I mentioned that.
Yeah, I didn't hear. Maybe I didn't
Yeah.
hear.
Yeah, I mentioned.
So the investigation from the beginning, you didn't wait until I stimulate you about insulin and pro-insulin C peptides. It's very important any patient coming to exclude any external insulin or anything outside, and that insulin antibodies also very important. Organ you mentioned liver and kidney and euphemy. I don't remember you told about CT or MRI abdomen or not?
Yes, I mentioned that, and I also mentioned endoscopic ultrasound.
Yes, yes. This is the diagnostic for insulinoma or any pancreatic mass, maybe isolate cell or non-isolate cell. في extra they mentioned during the calibration, they put insulin growth factors 1 and growth hormone. They mentioned that sometime this is an indirect marker of activity of insulin. Because if the non-isolate cell is hypertrophied or active, they will suppress insulin growth factor and the growth hormone will be low. Like we are testing the acromegaly, it is the same. يعني you are when the non-isolate cell is high, hyperactive, it will make growth hormone and insulin growth factor low. It will be indirect active that there is insulin activity as autoimmune disorder. We asked also about cortisol level. You mentioned after I mentioned for you. يعني as a differential, even we didn't catch the diagnosis, خلاص we will go to the most common, as you mentioned, all insulin and insulin antibodies and cortisol level, short synectin test, organ function, and you suspect insulinoma for confirming. I will do that imaging for it, and the treatment, as you mentioned, for your provisional. But يعني against that, the weight loss, and this is not common with insulinoma, especially when you didn't test the activity clinically during the examination. So you can manage the hypoglycemia by, as you mentioned, by MDT, frequent, not high carbohydrate meal. It will be a low carbohydrate meal. يكون like يعني it will stimulate more insulin and it will cause more hypoglycemia for her. And sometime, if you still not reaching the diagnosis, you will give empirical steroid until they confirm the lab coming. And if surgical, as you mentioned, not still fit for the patient, you will give octreotides, long-acting somatostatin. And regarding the medication to be reviewed, the carbimazole, you suspect that may be causing this, so should be reviewed to be changed to propylthiouracil. Sometimes also they give a carbose to catch the carbohydrate to make the carbohydrate too much going to be absorbed so fast, so causing less hypoglycemic attacks. Okay, so you reached يعني 80% or 85% of the case. It is a rare syndrome autoimmune, but don't forget خلاص you put some differential during examination. think you so fast to go to the abdomen, you forget the thyroid, its activity and its examination and its malignant transformation. So this is only my comment.
Okay, thank you. So I can ask what is the clear diagnosis now, or is it case for differential? Because I couldn't get the case.
No, he confirmed that there is sulfonamide, that carbimazole, since 2 years he's taking, and lastly started to have the symptoms. So, and they changed the dose, it will become more the maximum dose. He didn't ask about any changing of the doses. So when he changes the dose, and Teresa started to have these autoimmune symptoms of called autoimmune insulin syndrome with other differential insulinoma, hypocorticolism, secondary adrenal insufficiency, and alcoholic liver disease, and CKD. And this CKD against that, no sign of renal problem. But the main differential they mentioned, recurrent hypoglycemia secondary to autoimmune insulin syndrome. This is the main. And the differential, that logic, insulinoma, then secondary adrenal, then alcoholic liver.
So no addition here.
No addition because no pigmentation. He checked no pigmentation in the mouth, no pigmentation in the hand. The patient had secondary cause. They should search for the secondary cause in the brain.
Okay. In general, this I think this case appeared before. Did it appear before? I'm not sure really.
No, not appear before.
Yeah, so it's not common case. Okay.
But Dr. Basim, he will, if you didn't reach this main, but he will mark on the differential. You should
Yeah,
do it.
the approach on the
Yes, the
differential, yes.
approach, because
If
it is
it's difficult,
common,
yes.
يعني. It is common hypoglycemia, and يعني he bring it as a insulinoma, but against this as not Addisonian, because this may be secondary cause. Maybe alcoholic liver, he is alcoholic disease.
Yeah, these things should be rolled out, but the case itself difficult to catch.
Yes, difficult to catch. Yes.
Okay. Okay, thank you, Dr. Mohammed. Anyone has other question? I cannot comment really because I think if you don't reach diagnosis, it's difficult to say I do well. But the performance, as the picture there, you couldn't examine the thyroid, Dr. Ihtijam, as long as the patient already thyroid patient. Don't forget to do examination. So it can minus you in 2 marks and 2 skills, the physical and identify the finding. Otherwise, the history also some of the same, the approach. You are going according to the target question. You are not following a system review question per se or what I prefer to do. That's why I cannot also comment on this since you couldn't catch. So it will be like linked skills, as you said before, linked skill. The diagnosis itself related to the physical examination, related to the identify the finding, as well as the differential diagnosis. Here, at least, you put the insulinoma. For me, I will never put insulinoma if the patient is not weight gaining or gaining weight.
Yeah.
But it's difficult to say this is so. However, it's one of the differential. I don't know how. Maybe because of the hyperthyroidism, the patient is wasting and losing weight. So it's a difficult case, really.
Yes, Dr.
Yeah.
Basim, I
Okay.
just wanted to discuss that thing. So, if we are not putting insulinoma because of the weight, Edison, we didn't find any clinical signs of Edison, like no pigmentation and nothing like. If that's not the case, and if that both of these two they are out, so we cannot put autoimmune polyglandular syndrome. So basically, in that case, we will left with just autoimmune insulin syndrome and alcoholic liver disease. So I think catching an autoimmune insulin syndrome in the PACES exam, I mean, obviously, if you're working in an endocrinology unit, so maybe you are aware, but I don't know that if it that rare. I mean, the reason is that this kind of scenario of hypoglycemia, it is a common scenario in the exam, and we do get that. But most of the time, it comes as a part of either a Mann syndrome or it comes as a factitious one, or it may come as an addition. So I don't know that how likely it is to come it as a, or the examiner then look for the candidate to find a diagnosis of, or tell him the diagnosis of an autoimmune insulin syndrome. I don't know that. I mean, it would be brave of the candidate as well to commit that diagnosis, because in the exam, if you are committing a diagnosis, so at least you need to be quite sure about that. If you are not giving a differential and you're just committing something, and if you're telling the patient that you may have an autoimmune insulin syndrome, so I feel that it may be a little bit kind of a tricky thing to do. I don't know what's your thought on that.
Yes, I agree. I didn't appear before. I didn't hear about it in all my sessions. It's different. It's something beyond the paces. I don't know if appeared before. Even if there is any mentor mention it, I don't think it can come in paces. Anyway, as usual, advice. If you hear a case, know it for your future. It might come to you. You don't know what will happen in your exam, but I don't think they can even put it as first differential. There is a lot of disease can be as a one or a second differential, first or second differential. But such condition, it's difficult to be mentioned by history only. Something need to be as endocrinologist or to be repeated frequently in other diets to say this is the case and appeared before. So may possibly as a first time appeared, yeah, then the people or the candidate will know about it. Otherwise, I don't think anyone will know it. This is my the opinion and my advice. But anyway, do your approach. Try to get the marks for other skills, not only this skill. Okay. Anyone want to comment regarding this case or the previous one?
Doctor, can I comment?
Yes, Dr. Huda.
I think chronic liver disease and chronic kidney disease not cause severe hypoglycemia that's cause dizziness, only in the severe and advanced disease.
Yeah, but any chronic liver or chronic kidney can cause.
Yeah,
Okay.
but I think in the late and advanced, I think he discovered the jaundice and the ascites before the hypoglycemia.
There was jaundice in this case?
No, I mean
You
he
mean,
he
yeah, other
measured
finding of
symptom
chronic liver
before
disease
he
will
has
appear for the
hypoglycemia.
hypoglycemia.
And the
Okay.
chronic kidney disease also in the, I think more cause hypoglycemia patient with diabetic,
Yes, you're
who's
right.
take
Yes.
oral
Yes, you're
hypoglycemic
right.
or
Yes.
insulin. But in the general, we not see
Yes.
patient in
Yeah.
the real, he have hypoglycemia.
You
Okay,
know,
thank
Dr.
you very
Huda,
much.
I can put, yeah, thank you, Dr. Huda. You know, I can put on top of my differential in this case alcohol. Alcohol-induced hypoglycemia by the alcohol history.
One binge
Uh,
alcohol can he come severe
yeah,
hypoglycemia?
yes,
One
yes,
binge.
yes. It's okay. Yeah, yeah. So it's more fitting than what I the first time to hear about, but it's okay. Usually we are discussing those things because you don't know what will happen in the exam. But believe me, whenever the difficulty of the case reach to this level of difficulty, they will judge you or judge on your skills regarding the approach, the finding, the physical examination, the differential, the clinical communication, whatever you reach the diagnosis or no. Such the condition or such diagnosis difficult to be mentioned even from the history only. Anyway, know it. You don't know what will happen, as I said, but at least put the most common one. Okay.
Oh,
Anyone? Yeah, thank you, Dr.
yeah.
Huda. Anyone else? Yes?
Dr. Basim, I was like, when Dr. Ehtesham started talking and when Dr. Ahmed was like trying to say, but he was very clear from the first point that, he's taking carbimazole. And like, I think we know that one of the side effect of carbimazole is acute pancreatitis. So I think when he was taking the history and everything was negative, 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 no pigmentation, nothing like he did not have any signs of renal failure, nothing of the liver sort, that is going to desaturation. So ultimately, it was just narrowed down to maybe this is the drug, insulinoma, because I think Dr. Ehtesham was, from the beginning, he knew that insulinoma is the target question. So he just kept that the whole history was taken on that basis, I felt somewhere. And that's why somehow he was not even too much focused on the thyroid as well. And
Yeah.
I don't know, maybe I'm just taking it from my point of view, but and maybe I work a lot in endocrine section, so maybe I got that
Yeah,
carbimazole
it's
thing.
good, really.
But
Thank you, doctor. Yeah, to raise this point as a differential, could be pancreatitis. Yes, could be. Why not?
yes,
Yeah, so you can
and
yeah,
initial phase of pancreatitis can, because the beta cells are like dying, the
yeah,
insulin is rushing out
yeah,
of
yes,
the
yes.
and
Okay,
he is having
This is
the
the,
cases.
good,
this
good.
is the idea of this, Dr. Bassem.
Yeah.
This
I,
is
I mean, yeah, I think
Okay.
that how, yeah, how can you have pancreatitis without any pain? So if it
Okay.
is, you are thinking it is
Yeah,
a
but
recurrent
we
pancreatitis.
are not saying
So
this
I
is the
don't know
case.
that.
Yeah, we are not saying this is the case,
It's
Dr.
drug,
Hisham. We are saying
yeah,
as
but
a differential,
is
we
not a
can put it
pancreatitis. I mean, it is the
drug
same
induced.
physiology, drug induced. It is the same
yes,
physiology.
Okay.
yes,
I will ask
yeah.
Doctor, what's your good name, please, Doctor?
Aisha,
Dr.
I
Aisha,
think it
okay,
is not
because
coming.
yeah, it's
Yes.
coming Zoom user. Okay, Dr. Aisha, since
Uh,
you are endocrinologist, how frequently you are facing our diagnosis today?
the moment Dr. Ahmed said that, carbimazole and hypoglycemia, that's the first thing that struck to me, because we
No, no,
we talk a lot
no, no,
about this.
no. The one mentioned autoimmune insulin syndrome.
No, I haven't heard it too
It is
often.
carbimazole, Dr. Bassem. It is carbimazole induced
Induced
autoimmune physiology.
autoimmune syndrome. Yeah. This can be seen very often. Like this, we say, like Dr. Ahmed is saying, it's an autoimmune or idiosyncratic reaction of the drug causing hypoglycemia, and we say that carbimazole causes acute pancreatitis and causing hypoglycemia. So this is quite a frequent side effect that we keep in our mind when we deal with carbimazole, especially in the gynae department when the females are pregnant.
I really
And
volunteered by this
but then we
when he shifted to the family for the past history. I
mm,
mentioned he didn't ask me about the medication. From myself, I told him I am taking
carb
for 2 years
yes,
to
yes,
be
and
alerted that there is a problem in the medication. I thought he would catch it really, Dr. Hitch.
yeah, yeah. So yeah,
Okay.
that maybe that was the reason that, because we read
Yeah,
so
yeah,
much about it.
yeah.
Yeah.
Thank you, Dr. Aisha.
Yes.
Usually, this is advice for all of you. Whenever you
Yes.
are preoccupied with a diagnosis, from
Mm,
the start, you will miss the case because you will
mm,
try to cook the case as this is the case. I want to diagnose this. So the
mm,
all question will be directed to what I am thinking. I will close my eyes to other things. So
mhm,
you will be missing the diagnosis at the end. So as advice, general
mhm,
advice, don't think about the diagnosis to be fitting your case and don't narrow your differential to this preoccupied differential. Try to think about others. Follow your scheme. Even the question is negative, you don't know what the case, follow the scheme till the end. Please ask everything. I don't know, Dr. Muhammad and Dr. Hasham, till this moment, you are missing parts of the scheme, either family or drug or travel or the systemic
mm.
review.
Okay.
So it's a matter of following the approach, and they can judge you well on your approach. Believe me, even if you will not put the case as a diagnosis, they can judge well. So it's a matter of the approach again and again and again. The examination steps also to be organized, not only uh, doing the target things. Okay. Thank you, Dr.
Need to
Aisha
comment,
again.
Dr.
Yes.
Bassem, regarding
Yes.
this point from you, and really by our experience in such basis, usually if he give you a case and it is clear there is a straightforward diagnosis, make sure it will be not the diagnosis, it will be me second or third differential. because he know that you will catch it from the scenario and you will start thinking about it, but inside there will be a surprise there. So in my experience, that when I go on the scenario by the approach, but putting some general that I should ask about this. For example, our case today, hypoglycemia. I put in my mind when I attend the case, take it by myself, but the candidate, the examiner or the mentor was very happy for him. He go with the approach. He told him from the beginning, you will not. It is difficult case, and I am not waiting that you will reach the diagnosis, but I am waiting the approach. So from the beginning, خلاص we know that the common diabetes it's a complication. سواء gastroparesis سواء كذا, you can stop it from the beginning or exclude it from the beginning. Second one, adrenal and its autoimmune association. Third one may be organ failure. It is a common, and the age of the patient 50 years. It's a common. Maybe he has blood transfusion before his viral, his chronic liver, alcoholic chronic liver, traveling or كذا catch infection, TB, maybe يعني adrenal. And the candidate this time asked him any coughing blood, any travel, any contact to TB, clearly that he wanted to exclude this adrenal from the patient. So he waiting the approach. In many cases coming for differential waiting the approach. The other after organ failure, maybe the patient have a problem psychological. He's taking factitious from outside anything. So يعني what I mean, if you preoccupied and insulinoma, sure, insulinoma from the differential at the beginning, but you can finish it from one or two question. Any weight gain, what about appetite, what about كذا, he will had hypoglycemia and weight gain clearly. Even he has some hyperactive thyroid, his weight will be good, not loss of the weight. But loss of weight 4 kilos in 2-3 months is very significant. So what I mean that you can from outside have a general view for the case as a common case, but don't go inside and put in your mind, well, this is insulinoma until proved otherwise. So you can go the approach, and every track in the approach, he will give you a clue. And from this clue,
Yes,
at the end, and
exactly.
really, Dr. Basim, many cases I am attending with mentors, with you. I am not going inside the case and I put in my mind, well, it will be this case. When I collect everything, then I put the differential, and mostly it will be one of them. Maybe the how to put first one and second one, third one may be affected by this way, but at least you don't lose the case at all. And if you lose the case, you will lose the examination, you will lose the judgment, you will lose everything. So that's why I mean that you have a general view from outside that this case, this symptoms or this complaint mostly go to which system you will see, but don't go inside with some specific diagnosis, because you will really, as you mentioned, Dr. Basim, you will cook the case. You will wait to you will insist to take some symptoms from the surrogate to fulfill your criteria, and will be very
Yeah,
risky.
exactly. Yes, it's risky to lose the case at all. Okay. I hope. I think this is the last session, Dr. Hisham and Dr. Muhammad, before your exam, right?
Dr. Basim, I will attend at the beginning of the week.
Okay. Saturday, as a long. Okay.
No, I
Uh,
am available. I am available till.
okay. So we'll
Yeah.
give you another opportunity. I hope you can do. It's difficult cases. I know you are preparing for each other, but the
Yeah.
exam is so near. It's okay to be like this, to feel the difficulty, but
Yeah, yeah.
please follow the steps. Be more systematic. Be organized. Even if you're not reach diagnosis, show me the organized approach. Thank you, Dr.
Dr.
Hisham
Basim,
and
can
Dr.
I ask
Muhammad.
one?
Let's
Is,
yes,
Dr.
Dr.
Basim, can I
Shaina,
ask
right?
some?
Dr. Aisha.
Aisha. Dr. Basim, like in the cases, I have just started preparing. So should we reach to the diagnosis, or the differential diagnosis itself is enough? Like when we present to the examiner.
Okay, it's a good question, Dr. Aisha. I believe that if you put the first differential or second, at least differential for the case, you can gain the full mark with good approach, of course. Okay, not you have to fulfill the criteria of the scheme of the approach, systemic review, the family, everything you have to ask. Travel sometimes should be asked if you have infection or if you have like hepatitis, sexual transmitted disease. So don't miss those things. Let's go back to another point. I heard about a last diet in Oman. They brought a case of recurrent fall. Okay, recurrent fall, and the feedback was recurrent fall. It wasn't diagnosis. See, what is the diagnosis? Or in the feedback they are writing in the box up in the paper, the diagnosis or the case is about, for example, recurrent fall. So the complaint was recurrent fall, and the feedback, the case was recurrent fall. And the comment for the candidate was he fulfilled the differential, he got good differential, he put good management plan without mentioning a clear diagnosis. It was a complaint. Don't tell me recurrent fall is a diagnosis, right? So
Yes,
it's a case for differential. And he got good mark since he mentioned the autonomic neuropathy because patient was diabetic. The
okay.
autonomic neuropathy, he mentioned the TIA because he's long-term diabetes, so he has dyslipidemia. He mentioned the cardiac, along with the history taking. He tried to rule out all the cause of hypoglycemia and the cause of TIA while taking history, the cardiac cause of syncope, and he got good mark because he put all of these things in his scheme, and he put it in the differential, he put it in the management plan, investigation, and the examination steps. What I mean, it's not a matter of diagnosis. Sometimes they give you the complaint and they want you to approach well to this complaint, not by only one diagnosis. Okay, you got it,
Okay,
Dr.
Aisha.
Aisha.
Yeah,
Yeah,
sir,
so
one more thing.
I saw this by my eyes. Okay, continue.
Sir, so when we give the differentials, like Dr. Hatasham, Dr. Ahmed, they all are giving the differentials, so we don't have to justify. Do we have to justify that why
Yes,
I
you
am
have to
putting this?
say. Yes, yes,
Okay,
sure. Sure.
okay,
Or
okay,
he will ask you why you said that. But
okay.
based on clue in his history,
Mm-hmm,
if you show him that you ask about these things to roll
mm-hmm.
out or to roll in this differential, he will understand that you are asking professionally. You are not just
Okay.
asking randomly. You are asking to roll out something you want to say, either this is the case or not.
Mm.
Oh,
Thank you,
anything
sir.
else,
I
Dr.
need
Thank
Aisha?
to complete
you.
one thing for this question about the doctora. Uh,
Mm-hmm,
the against the against or the other way, if you get the diagnosis,
mm-hmm,
you get the diagnosis and it is the
yeah,
first or second differential, but
mm-hmm.
your
Yes.
approach not good, and you didn't put the differential as they put in the
Yeah.
calibration.
They will
Be
minus.
sure that yes, he will minus too much because he will
Yes.
feel that you know the
Minus.
case and you are coming
Yes.
you buy it by it. فتake care. يعني it is not a matter of that. It is a balanced approach it well and put a good differential, very sensible differential.
Yes.
Mm-hmm.
The most one to be first or second at least. This is you
Perfect.
will be high marking, inshallah.
Inshallah, inshallah.
Perfect. Yes, I agree with this. Don't give randomly scheme or approach, then you wait for good mark, even if you mention the diagnosis, because the case might be easy. I had a case of, for example, like today, insulinoma.
Mm-hmm.
So I just ask randomly question. I miss the weight, for example. I miss something, history taking of medication, maybe medication induced, and occupation. I missed the driving, and I'm saying, oh, I did the case well. I said this is insulinoma. What about the clinical communication? What about the examination? You didn't fulfill the all skills. So don't wait to give to get good mark if you don't fulfill the all skills. This is another good advice. Thank you, Dr. Muhammad. So it's a matter of approach and being logic while giving the differential. Put your differential that makes sense for you and for the examiner, and wait for a good mark. Thank you, Dr. Hisham and Dr. Muhammad. Dr. Aisha, anyone want to ask any question before ending the session? Okay. So see you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.